Good evening, everyone. So tonight, tonight I'm going to talk about the liver Doppler ultrasound. So can hear, right?
Can.
So this is today's
Yes, ma'am.
objectives. So we'll touch a bit on Doppler physics. After that will be the liver vasculature. So after that, I'm going to talk about the liver Doppler characteristics and imaging protocol and Doppler findings in the common clinical conditions and image optimization, advantages and limitations, and the summary. So Doppler physics. Doppler shift refers to the frequency change of ultrasound echo is caused by relative motion of the source to the receiver or vice versa. Positive Doppler shift is the source and the receiver is moving towards each other. The negative Doppler shift is the source and the receiver is moving away from each other. So this is the Doppler equation. This Doppler formula is used because the transducer is not parallel to the axis of the moving object. So the Doppler angle is the angle between the Doppler ultrasound beam and the direction of the blood flow. The angle is 0 unless specified by the operator using the Doppler cursor. When the Doppler angle becomes more than 60 degrees, the potential effect on the error in velocity measurement is become unacceptably high. The angle correction is considered accurate for diagnostic purpose at the installation of angles less than 60 degrees. So we are talking about the liver vessel anatomies. So the portal vein, the first will be the portal vein is constitutes 75 of the hepatic blood supply. Is deoxygenated blood carrying mainly nutrients. It's formed by the confluence of the superior mesenteric and splenic veins. The portal vein drain out the upper and mid part of the gastrointestinal tract, pancreas, gallbladder, and spleen. The blood that enters the liver after absorbing the nutrients from the intestine through the portal vein. It divided into two branches, the left and right portal vein, and the left and posterior branch. So the hepatic artery is the supply 25 of the hepatic blood flow. It constitutes the main bulk of the oxygenated blood flow to the liver. It's arising from the celiac artery. The hepatic vein are the three branches, the right, left, and main hepatic veins draining blood to the IVC. First, hepatopetal flow refers to the blood flow towards the liver from the portal hepatus towards the liver periphery. It typically is used in describing the normal blood flow direction in the portal vein. This occurs in the normal liver and allows the liver to detoxify. So the portal vein will be the same direction flow as hepatic artery. Both are towards the liver. So in ultrasound, 2D ultrasound Doppler will demonstrate in right color. Hepatofugal flow refers to the blood flow away from the liver in the portal vein and is sometimes referred to as the retrograde flow. In the other word, the portal venous blood flow pattern is from the periphery of the liver towards the portal hepatus. This occurs when the portal venous pressure is high in the case of the portal hypertension. Thus, the portal systemic shunt are reopened with additional findings that include a more narrow portal vein and prominence of hepatic artery. Occasionally, a to and fro bidirectional blood flow pattern alternating between the hepatic pedal and hepatic fugal flow can be seen in the portal vein before the onset of the flat hepatofugal flow. So this is a picture. We can see the portal vein is blue in color. It's different flow direction with hepatic artery. So the ultrasound period, normal ultrasound Doppler characteristics of portal vein will be like velocity will be reached from 15 to 30 centimeter per second. Velocity decrease in inspiration and increase in diameter. A broad undulating waveform due to respiratory variability is a hepatopedal flow direction. Is the diameter will be measured up to 13 mm. So the interpretation of the portal vein flow. So the normal flow as we have discussed. So this is a bidirectional flow which happen in portal hypertension or heart failure patient. This is the reverse flow can also happen in like advanced portal hypertension cases. So hepatic artery, the blood flow velocity can range from 30 to 60 centimeter per second. Diameter measure up to 3 mm. The low resistance Doppler waveform, the R will be reached from 0.5 to 0.7. Interpretation of the hepatic artery flow. This is the normal low resistance flow. Elevated RI with low diastolic flow can happen at end-stage liver disease. Furthermore, the diastolic can be reversed in some patients with end-stage liver disease. Hepatic vein. The hepatic vein waveform is typically described as a triphasic. It varies with the cardiac cycle. This waveform is influenced by the pressure changes in the right atrium and reflects the hemodynamic status of the heart and liver. Variations in flow are seen during the respiratory cycle, with the flow increase during inspiration and decrease during expiration. The normal hepatic vein Doppler waveform is classically described using the 4 waves. So the A wave, the atrial contraction causes retrograde flow back to the liver, then the rapid IV filling. The S wave is a ventricle systole, antegrade flow into the right atrium against close the TV. The V waveform, opening of tricuspid followed by a rush of antegrade flow. The D wave is the ventricular diastole, antegrade flow into the RV. So the interpretation of the hepatic vein spectral waveform, the first we look at the direction of flow, whether if there's no flow or reverse flow, it could be the Budd-Chiari syndrome. If antegrade flow, then we look at the regularity of the flow. If irregular, with the patient or technical factor, could be a patient or technical factors. Also could be arrhythmia. So after that, we look at the phasic, the phasic of the flow. If it's monophasic, is could be due to the fatty liver cirrhosis. Budd-Chiari syndrome also can be due to high blood pressure, high abdominal pressure. After that, if the flow is a biphasic or triphasic flow, we'll look at the D wave and S wave. If D wave or the S wave, it could be due to some heart problem, the right heart problem, or right cuspid regurgitation. So if D wave smaller than S wave, will be a normal flow. So I'm going to discuss about the imaging protocol, the equipment. So it's a high quality ultrasound with the color Doppler, power Doppler, and spectral Doppler capability. A curving linear transducer with a frequency range from 5 to 1 megahertz will be used. So this frequency range allowed for high resolution of the deep structures within the liver and adequate penetration of the big hepatitis patient. Patient preparation, like 6 hours fasting as required, and small amount of water is allowed. This is our imaging protocol. So for the portal vein, the left right and main portal vein will be imaged with grayscale color Doppler and spectral waveform. The peak velocity will be measured. The scanning window for the left portal will be subcostal, and right and main portal will be the intercostal. For the hepatic artery, we only assess the main hepatic artery. So the color Doppler and spectral waveform will be the images will be taken, and the measurement will be RI, systolic velocity, and diastolic velocity. The scanning window will be intercostal. Hepatic vein, like the three branches, left, mid, and right hepatic veins, all grayscale color Doppler and spectral waveform will be taken. There's no measurement required. So for the left hepatic vein, normally is subcostal. Then for the mid and right hepatic vein will be subcostal and intercostal, depends on patient habitus and patient condition. So the splenic vein and IVC will also be assessed. Like both grayscale color Doppler and spectral waveform all will be taken. No measurement required. For splenic vein, normally we use intercostal. And IVC, both subcostal and intercostal, depends on patient conditions. Okay. Okay, the common indications for a liver Doppler study will be portal hypertension, Budd-Chiari syndrome, portal vein thrombosis, evaluation of tips, and hepatic venous congestion, transplanted liver. It's not covered today as our center we seldom have such cases in our center. So the portal hypertension, dilated portal vein, for the ultrasound appearance is dilated portal vein more than 13 cm is not specific as an isolate findings. Decreased portal vein velocity less than 60 centimeter per second. If we canalize the para-umbilical vein, velocity may be increased. A positive portal vein may form as pressure increase by phasic or reverse flow in the portal vein in late stage of portal hypertension. The hepatic artery you see elevated RI is more than 0.7. So this is a portal vein waveform with a positive waveform. So this is bidirectional. This is a reverse portal vein. This is a reverse portal vein flow. So next, so other ultrasound findings can be enlarged spleen up to more than 13 centimeter. Ascites, the portal systemic collateral vessels like esophageal varices, recanalized umbilical veins, and splenorenal collaterals. So this is a picture with recanalized umbilical vein. So this is a picture with splenorenal collaterals varices. Next will be a Budd-Chiari syndrome. The specific ultrasound findings are showing like narrowing, lack of visualization of hepatic vein and IVC, filling defect within the hepatic vein and IVC, accessory hepatic veins and collateral veins, absence of flat flow of hepatic vein. So the reverse flow in hepatic vein and IVC or both. So this is a hepatic vein spectral waveform with the like very monophasic flow. They lost the triphasic flow pattern. Okay, so the non-specific ultrasound findings can be portal vein flow changes from change to bidirectional or hepatophagal flow, increased RI of the hepatic artery, enlarged liver, inhomogeneous liver parenchyma, enlarged spleen, ascites, left and caudal lobe hypertrophy. So this image showing enlarged caudal lobe. So next one will be the portal vein thrombosis. The 2D scale you will be see filling defect within the lumen. For the color Doppler, if there's no absence of the color Doppler, that means it's complete thrombus. If partial thrombus, you still can see that partial the lumen is filled with color. For the pulse Doppler, there's no signal detected. For complete thrombosis, like some signal will be detected for the partial thrombus. So acute portal vein thrombosis, the portal vein can be dilated, and also the feeding defect can be hypoeconic, or this one can be easily missed. So this is a picture showing a partial thrombus. You can see there's a feeding defect over here. And on the color Doppler, we still can see some flow within the portal. For the chronic portal vein thrombosis, you can see small vessel caliper, calcification within the thrombosis, and cavernous transformation, and peripheral varices. In the setting of non-malignancy, tumor in the vein must be considered. It can be diagnosed by the presence of arterial flow in the thrombus at the spectral Doppler ultrasound. So next will be the air in the portal vein. So ultrasound is a more sensitive imaging modality for diagnosis of the portal venous gas because the mobile echogenicity bubbles are easily appreciated, similar to the bubbles of ultrasound contrast material. So this image, this 2D ultrasound image showing the multiple echogenic foci in a vascular distribution throughout the liver, representing the portal venous gas. At the real-time imaging, the echogenic foci move peripherally in a direction of portal venous flow. So this spectral waveform demonstrates a classic waveform seen in the presence of the portal venous gas with numerous thin spikes over here. Okay, so next one will be the tips. The tips relieve the high pressure in the portal vein, the portal hypertension. It allows the blood flowing into the liver from the portal vein to flow through the tips, then directly into the hepatic vein that drain the blood out of the liver to IVC, and then immediately into the heart. So the normal tips velocity will be range from 90 to 190 centimeter per second. The normal portal vein velocity before entering the tips is around like 30 centimeter per second. It's a phasic waveform. The portal vein branches normally reverse their flow into the shunt. So this is how we see a tips in 2D color. The velocity is high, so normally if you then increase the scale, normally you will see there's a big aliasing. So this is the velocity. We can see it's a normal tips. The velocity is above 90 centimeter per second. Stenosis tips. Color Doppler imaging at the site of the stenosis. Velocity of will be more than 190 at the stenotic segment. Velocity will be less than 90 at the non-stenotic segment. Velocity will be less than 30 centimeter per second in the pre-stem portal vein. This is accessory sign. So complete conclusion is a lack of color Doppler flow. So this two picture is showing a complete conclusion of the tips. There's no color flow. You see there's some feeding defect within the tips. Okay, this is another case with the stenosis tips. You can see there's some narrowing with aliasing within the tips. But so on the spectral waveform, you can see a high velocity at the narrowing side is about 190 centimeter per second, and at the non-stenotic segment, you can see it is below 90 centimeter per second. So next, I'm going to talk about is like hepatic venous congestion. Hepatic venous congestion is primarily caused by the increased central venous pressure, often due to the right side heart disease. Like some related condition can be like some heart failure or like tricuspid regurgitation. So the ultrasound appearance, you can see like dilated IVC more than 2.1 cm, dilated hepatic vein, abnormal spectral waveform of hepatic vein, loss of normal loss of normal traffic flow pattern. Spectral signal may have a M shape, an S wave smaller than or reverse from the D wave. Increased RI in hepatic artery and increased partiality of the portal venous Doppler. So this is how this is a normal hepatic vein form looks like. You can see the 4 waves ASVD. Then for the moderate congestion, you can see the S is smaller than D. And in the severe condition, you can see the S is reversed. So other ultrasound findings you can be like enlarged liver, or you also can see cirrhosis. As like severe hepatic venous congestion can lead to secondary portal hypertension. Therefore, ultrasound may also demonstrate typical features of portal hypertension. Next one will be I'll be talk about image optimization. So first is 2D image optimization. Ensure the 2D image is clear and well adjusted before adding the ultrasound Doppler, as a per 2D image will result in a per Doppler imaging. So the gain, depth, TGC, focus, scanning window, proportioning, all this need to be optimized. The image on the left showing the per blood flow visualized in aorta as it too far from the transducer. In order to assess the aorta well, we should change the window scanning. Like for this case, we should go to the subcostal. The image on the right showing there's no vascular flow in part of the main portal vein because of the ultrasound beam is perpendicular to the direction of the blood flow. To ensure the patency of the portal vein, we should try to change put positioning, use heel-to technique, or try different window. Try to see whether it's a technique problem or really there's some troubles there. So next will be color Doppler optimization. So the color gain, fine-tuning color gain to eliminate the background noise. You may need to readjust it as flow state change throughout the study. So the velocity scales should be set to minimize aliasing, which cause when high velocity are incorrectly displayed. Also to ensure it's not set too high to miss the low velocities. The color box, make it as small as possible while still encompassing the region of interest to increase the frame rate and improve the Doppler sensitivity. The wall filter, it can be helpful to filter out the low echo frequency shifts that can occur due to movement of soft tissue and vessel walls due to reduce the noise on Doppler interrogation. The wall filter can be adjusted to remove these low velocity signals in the post-processing. However, as the filter is set by the user, it's always important to note that the setting of the wall filter too high will remove the true low velocity flow information. So look at these two examples. The first one, scale is too low. Aliasing is seen within the portal vein. After change the scale, the portal vein is well demonstrated. So the second one, the PV is well seen, but the SV is not filled with the color. You see the portal vein, the hepatic veins are not filled with the color. So this is because the wall filter is set too high. So after we adjust the wall filter, the hepatic vein are seen filled with the color nicely. Next one will be the pulse waveform Doppler optimization. Similarly, we need to adjust the color gain, velocity scale, color box, and wall filter for the pulse waveform Doppler. So the sample gate, adjust the sample gate to a proper size for the vessel. A smaller gate provides a clear signal for precise measurement. while a slightly wider gate may be needed when searching for a weak flow or for uncooperative patients. So Doppler angle, again, setting it as close to 0 degree as possible to the direction of blood flow, never exceed 6 degree, uh, as an angle above 60 degree lead to inaccurate velocity measurement. To achieve this, you must align the Doppler cursor with the vessel and if necessary, use the skills like changing window, heel-toe technique, adjusting the transducer positioning, and so on. So this is some examples. The image on the left showing the spectral scales is set too high. The flow is more difficult to appreciate and characterize on the scale. So the image on the right showing the ultrasound image obtained within a high wall filter setting. It can be said that loss of low velocity flow component of the spectral waveform immediately above the baseline. You see above this the baseline, above the baseline there's no signal. That means the wall filter is set too high. Now is the advantages. It's like ultrasound is cost effective, is widely available, and is non-invasive and safe. There's no radiation involved. There's no contraindications, and it's real-time imaging. Limitations of is like ultrasound is operator dependent, or the operator skill and knowledge will play a very important part. Patient dependent limitations, like whether patient can breath hold during the study, and patient size for obese patient, we always have the penetration problem. And limited scan windows due to the patient's body habitus like high riding liver or gassy abdomen. In summary, liver Doppler ultrasound is the first technique used in assessing the liver vascular conditions. Understand of the liver vasculature, normal and abnormal vessel Doppler characteristics is required to successfully perform a liver Doppler ultrasound. Image optimization techniques and the expanded knowledge of instrumentation applications, advantages and limitations of this modality are of utmost importance.